So the webinar number 11, Diagnostic Studies in Evidence-Based Practice of Manual Therapy. Among the Century Webinarathon, New Year 2020 to 21, from 1st December 2020 to 31st March 2021. Initiative from the AOMPT to reach each and every corner of the globe to share the important information related to professional development and knowledge, to unlock the ignorance by empowering the knowledge as we unlock into a world free of COVID-19. So I see that many of you are attending the webinars, but you are not able to get certified. Okay, people are not aware of what to exactly do. So I want to tell you first thing that remember that there are 4 social media platforms. Okay, I have already put that message in the group also, the WEBINARATHON group. So in all the 4 social media platforms, you are supposed to like and follow AOMPT so that you get all the updates. That is first step. The second step, for every webinar there is a post. Okay, so there is a post which is there in all these platforms which you are supposed to track it. Don't expect me to send the links for every webinars. Okay, and as you track, you see the post for that topic, you comment there. Okay, if it is Twitter, you are supposed to retweet with your comment or your suggestion or your question. Okay, so that screenshot of your comment, you are supposed to submit it to me in the WhatsApp. For every webinar you get 4 screenshots, for one for YouTube, one for the Facebook, one for the Instagram, and the other for the Twitter. Okay, so you submit 4 screenshots every webinar, and then you are going to get the e-certificate. Okay, the whole process is totally free. It takes hardly 10 minutes. Signing up in these platforms is also takes hardly 1 to 2 minutes. So it's really very, very easy and simple process. If someone is not aware of this process, I don't think so that what you are doing actually in the lockdown. Okay, if commenting on YouTube you don't know, retweeting on Twitter you don't know, or commenting on Facebook you don't know, or commenting on Instagram you don't know. Okay, I definitely believe that most of the physios are any picture of a girl comes on Instagram means nice pic, you are looking beautiful. Okay, we always comment. So why is there a difficulty to comment for a academic topic? Okay, YouTube videos we always comment. Okay, because we see any kind of a movie, we tell nice movie. Okay, so that means you know how to comment on YouTube. Facebook also, we know someone's birthday, HBD. Okay, someone got some award from somewhere, you don't know where they got it from and why they got it, you will tell congratulations, 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 congratulations. Without knowing only we are commenting. Okay, when we are learning something and we are attending a webinar, why are we not able to comment? Okay, retweeting in Twitter also, many of us retweet whatever Shah Rukh Khan has posted, we will immediately retweet without even seeing what it is. Whatever our honorable PM has tweeted, everybody will retweet. So retweeting is not a new process at all. Okay, if you still don't know anything, when you don't know what you do, you search for the steps in Google. Okay, you don't keep asking people that the instructor itself that what I should do. Okay, how I should do. Okay, I am not here to teach you Twitter and Instagram. Okay, I am here to teach on these platforms, and I am switching the platforms so that all the 4 social media platforms reach everybody. Okay, I again put forward my request that remember that learning is first priority. Okay, and for the learning that you dedicate the time, I am giving you the certificate. Okay, you should also make sure that the knowledge should reach maximum people by lobbying and spreading the word, making your friends to join. In fact, each person should ensure that at least 50 people, they should make them to be aware of this kind of things. Because if you think it's an ordinary effort, holding 100 free webinars in the matter of 120 days, okay, that means you really don't know the value of efforts and perseverance. Okay, the amount of knowledge that is shared by AOMPT, definitely you will not get it even by paying huge amount of fees from any resource person anywhere in the world. Okay, If someone can take better on that particular topic, you show me that video, okay? I'll give you free membership, and I will also assure that all future courses of AOMPT is free of cost for you, okay? I'll make sure that it's free. It's an open challenge, okay? With even the challenge to the established resource persons all around the world also, I am telling, okay? If anybody can explain better on an online platform like this, okay? Direct, yeah, you can use PowerPoints, you can use videos, techniques to demonstrate or to teach, or even you can utilize practical training, supervised, okay, group teaching or individual teaching, okay. On an online platform as a webinar, when a speaker is speaking for 1 hour and if he is giving the topic in the 40-45 minutes, if someone can get statement, it's an open challenge, okay. So make sure that you physios and students realize the responsibility that we have for each other. Make sure that your friends also learn, okay. Unless all of us learn, profession will never be the best, okay. Individuals can become easily the best. Becoming best is the easiest thing, but becoming the greatest comes with making others the best. So work towards making others the best, okay. So coming to the topic, the webinar number 11, Diagnostic Studies in Evidence-Based Practice. This is the part 2 of the video because part 1 got interrupted. So I am continuing. Diagnostic studies. So that means you are going to assess. Okay, you are going to check for a particular finding in a patient, for a particular condition. Okay. So that is something which is an important part in a first contact practice. Whenever you do a kind of a physical examination or you do a radiological examination using MRI, CT, radiological. Okay. Physical examination is what you test on the subject, okay, directly, by making them to move, by testing the muscles by their contraction or by palpation, or you check for mobility, okay, you check for functional evaluation by questionnaires, or you make them to do the 6 minutes walk test or step test, okay. So various functional tests. Every test, whatever is considered as a part of an assessment, okay, it's for the diagnosis. If you are checking the range of motion using a goniometer, you need to know what is the normal range of the mobility, okay, the degrees. So if it is elbow flexion, that means 140 degrees, okay. It's not 140 exactly, you know that it can be 135, it can be 145, okay, plus or minus 5, and compare to both sides, within 5 degrees difference it should be there. This is something called as normative value. We need to know the normative value so that in our assessment, the subject presentation, we can tell whether something is abnormal. So studies on normative data is also diagnostic, okay. And then the next one, comparison of normal versus the symptomatic. That means in people who are having elbow stiffness, the elbow stiffness could be rheumatoid arthritis, or it can be a post-operative or post-traumatic stiffness, elbow, after fracture or surgery. So that stiffness, range of motion will be limited. So you might have 90, you might have 70. So you are trying to see comparison with the unaffected side. Okay. This becomes the control and this becomes the case group. So it's a case control study. Or I have a stiffness, you compare me with another subject who's not having the stiffness of elbow. So you're checking the range of motion and comparing in order to associate what is called as the mobility with the disorder. Okay, so if there is rheumatoid arthritis, whether the range of motion is getting reduced. So this kind of studies, case control studies, involve kind of a matching, because you compare me with another person, you should ensure that he is also 6 foot height, okay, 6 feet. He is also near the 85 kgs body weight. Okay, so you might match according to the body mass index, and then you might match according to my lifestyle. Okay, he should also be sedentary. Okay, he should also be a brilliant physical therapist. Okay, so you compare all the characteristics. Okay, even with nutrition also. Okay, the type of diet, everything, because mobility depends upon various factors. Okay, and you should take the measurement of my range of motion in the morning 10 a.m. You should take the range of motion of the other person also at morning 10 a.m. and the other person should also be in Bangalore. Okay. So what I am trying to say is, you should make sure that all the conditions are matched as much as possible. These conditions are called as confounding variables. So you try to control them by making them similar between the groups, and then you compare people with and without rheumatoid arthritis, or post-operative stiffness means this side operated, this side not operated, or this side operated, so you are making this as case group, this is not operated, so you are keeping it as a control group. Okay, so case control studies. That is also diagnostic. By diagnostic studies, we actually mean observational studies. Okay. What we next do at this level is also cross-sectional. We take a survey. We wanted to see how many physical therapists are having low back pain. Prevalence of low back pain among physical therapists. So in this, we are getting a data that we surveyed around 1,000 physical therapists and we got around 140 people having low back pain presently. 700 people have low back pain in the past, or one point of their life they had low back pain. Okay, at least for 3 days. Okay, so this is my criteria. So I find that it is 740 people, so it is like 74 percentage point prevalence. It's called as period prevalence is there. Past 1 year, how many had low back pain? So that is the 1 year prevalence of low back pain. So these are all cross-sectional studies. You get a data low back pain, but still you will try to identify which are the factors which are actually related to the low back pain. Those who had low back pain, what were their factors which were different from those who did not have the low back pain? So in a cross-sectional study also, we will compare between people who had low back pain versus who did not report low back pain. Okay. This reporting is like self-subjective. The subject is telling. Sometimes you might screen for low back pain using radiological, or you might take, if it is for rheumatoid arthritis, you will take some measures like rheumatoid factor being positive. Okay, so you have some diagnostic criteria for every disease. Okay, so that you will utilize and see whether those are present, and see that smokers versus non-smokers, whether it was affecting, or whether it is a lifestyle sedentary versus active. Okay. Sedentary people had more low back pain. More people who had low back pain were what is called as in physical therapists only. They were supervising jobs. Okay, not in the one who is technically doing at the treatment level. They are managerial level. Okay, so you might find lot of findings. So cross-sectional studies are also important. They are easier to perform. You are performing at one point of time. You need not match subjects for anything. Whatever data you are getting, you are going to group them and then do secondary analysis and find out some important information through statistics. The merit of that cross-section study is time consuming. You can do short time, you can do maximum data. The difficulty or the challenge is it's very difficult to analyze, very difficult to write and report. Okay, cross-section study. So remember that something that is easy in some aspect, it will be difficult in the other aspect. That is science. Okay. Case reports, one single subject. Okay. You have been treating every day. Now you found that the patient had a unique disorder. He came with a diagnosis of what is called as Hiramaya disease. Okay, cervical spine. You'll be thinking, what is this Hiramaya disease? Sjogren syndrome. Okay. So these are all unique conditions are there, and this patient was taking some treatment. He was misdiagnosed. He was given some treatment which was as per the misdiagnosis, but later investigations have shown that this is the diagnosis, so the clinicians concluded something. So such kind of a study could be reported as a case report, unique clinical presentation. Okay. A patient with low back pain had come to you, but you are giving all the therapies, patient is not responding or worsening. Later found out that the pain is been shifting in the back, non-mechanical. Then after that you are asking some kind of history, gastrointestinal and then urological, and you find that the patient has recurrent urological symptoms. And then you found out by referring to a nephrologist that he performed diagnostic ultrasound, and then they found renal calculi. Okay. So Dr. Deepak Sebastian, he had published an article in the Journal of Physical Therapy where he reported a case like this. Okay, so it's a visceral cause of the low back pain. So single patient. So that is case report. That is also observational, that's also diagnostic. It can be therapeutic, you can give the therapy, but it's usually the traditional standard care therapy. It's not a new treatment. Okay? If you are doing it as a new treatment, it becomes a case study. The case study is experimental. Case report is observation. Okay? The next, of course, in the observational or the diagnostic studies are mostly on measurement properties. I was telling you about normative data. Okay, you can do normal value studies and all those things. In the measurement properties, what you need to see is there are two main properties, that is reliability and validity. Reliability is the accuracy of the finding between the same examiner when he does now versus the same examiner when he does after some time. That is intra-rater. Okay? Between one examiner and the other examiner, that is inter-rater reliability. If it is to do with the performance or a procedure, okay, this is the terminology. But if it is not a technique which we are performing, it is just a printed questionnaire, I give or another person gives, is anyway the same, okay, because it gives the instructions, subject reads it and they complete it. Okay. So that is actually not called as intra-rater or inter-rater, it is called as test-retest reliability. Okay. That's for questionnaires. So these are the types of reliability. There are some other types of reliability like internal consistency, okay, percentage agreement. So different types of reliability are again explained in the research methodology webinar package of the AOMPT. So get access to the 10 videos. You will definitely get a better perspective. Okay. For validity, it is actually an accuracy of the measurement irrespective of what is called as whoever is doing. Okay, that's the accuracy of the measurement. So that situation, it is depending on the tool directly how the measurement is accurate. Okay, just allow me some seconds. Okay, so back again. So that means I am doing a special test, positive, negative. Okay, I am doing a lab test. I have a value which is beyond the normal level, which is below the normal level, within the normal range. Okay, so everything comes under validity. That means whether it tells abnormal, whether it is really abnormal. Okay, if it tells normal, whether it is really normal. The characteristic of finding out is based upon the positive rate. Okay, false positive and true positive. That means false positive means in normal subjects also it's telling abnormal. True positive means in abnormal subjects it's telling abnormal. False negative, that means abnormal subject but the test is telling normal. Okay, and true negatives, abnormal subjects, the test is also telling abnormal. Okay, so these four measures are used to calculate two factors, that is called as sensitivity and specificity. Specificity is the ability or the validity where we are trying to rule in a disorder. That means if the test is positive, how much it can confidently say that the disorder is present in that subject. We might get an AdSense test positive. Does it really mean that the subject has thoracic outlet syndrome? Okay, so that means the test versus the disorder. Okay, how accurately it can tell, ruling in the disorder. That is specificity. Okay. Sensitivity, on the other hand, is ruling out a disorder. Just a moment. Are we back? Yes. So, what is important here is the sensitivity is for ruling out. That means the negative test finding, does it really mean that there is no problem in the patient? Okay. Specificity is positive test whether actually tells it's the problem in the patient. That is specificity. Sensitivity is negative test finding whether it really tells the subject is no disorder or normal. Okay. So these two are very important factors. Overall diagnostic accuracy is another measure. Validity again in detail was examined, it was explained in previous webinar videos, so get access to that from AOMPT, get that better perspective, okay, to improvise, so that you can also do studies on reliability and validity. It's very, very important to do studies on diagnostic properties, because without diagnosis there is no treatment. Don't go for experimental studies and randomized control trials, thinking that they are highest level of evidence when we don't have a diagnostic evidence. Okay, so always try to see that we should fill the gaps right from the fundamentals. So diagnostic evidence is very important. How do we say that it is low back pain? Then you see treatment benefits on low back pain. Okay, then you compare the treatments. Okay, so make sure that diagnostic evidence is very important. The next level of diagnostic evidence after reliability and validity is the questionnaires development. Okay, you can develop a new questionnaire, you can develop a functional scale, you can see and you can validate that questionnaire. Okay, it can be even an already established questionnaire which is used in English, but you want to translate it to Kannada because you are in Karnataka. That means you will translate and back translate into English, and it develops a process of validation again. Cross-cultural adaptation, it's called as. So that means it might have been used in stroke, not yet used in traumatic brain injury. You can cross-culturally adapt. If it was used in English language, the questionnaire, and then it's translated to Hindi again, it can be cross-cultural adaptation. So make sure that you are on track to establish a newly developed or adapted version of that questionnaire. You might take permission from the previous author who published the questionnaire, so that I am adapting it like that. It's definitely a must. Even if they tell that the questionnaire is free, it's open access, still you contact the author, get their consent, then you do that. It will always help you in peer review. You can send your manuscript, get their opinion. You can involve them as co-author, and you can publish. Okay, as I was telling, for searching for evidence. So you have got a diagnostic study across these platforms. It may be normative data. It can be normal versus the abnormal comparison, case control. Or you are taking a cross-sectional study, and then you are seeing for people with disorder versus people without the disorder. Okay, so you can compare in multiple aspects and make sure that you are on track to identify the abnormality. After the case so you heard the bell, okay, the ringing bell in the previous part. So after the interruption, I am continuing as the part 3, the webinar number 11, Diagnostic Studies in Evidence-Based Practice. So make sure that you are clear whether you are going to do a normative data study, or you are going to do a case control study, or a cross-sectional study. And then you see for reliability validity studies, the diagnostic, which is accuracy, okay, of the diagnosis tests. Okay, and then you can also extend it to further part of diagnosis, which is like observational study, which is a follow-up study to see what is called as the prognosis, okay, the cohort studies. So remember that every type of study is important in diagnosis, and diagnosis is important to establish evidence before we do research on treatment-based studies. Okay, coming to how to do these kind of studies, okay, how to make sure that we are doing in the right methodology. We have global networks like Equator Network, okay, equator-network.org. It provides what is called as reporting guidelines. So they mentioned that we can use STARD, S-T-A-R-D, okay, STARD guidelines for the reliability validity studies, STROBE guidelines for the observational studies, which is case control, cohort, okay, all of them, cross-sectional studies, you can use that. And for case reports, CARE guidelines. Okay, so different reporting guidelines are there for different type of study design. Okay, so you can just do that, follow the checklist, so that globally it is accepted that you have used the standard format of reporting. You did not withhold some kind of information. You also ensured that the quality of the conduct of the study was in par with the international standards. Okay. Journals like Journal of Manual Manipulative Therapy, we always insist, okay, that manuscripts that is submitted we publish case reports. Okay, it's very, very important. Case reports are actually the fundamental of clinical practice. Okay, in physical therapy journal, when you see 1960s, 70s and things, when it evolved as a good scientific journal, it was only case reports which were there. Okay, so it tells in-depth evaluation and then treatment and documentation, outcome measurement, all that. So it's very, very important that we do case reports and more than the randomized control trials, because randomized control trials may not reflect reality. The criteria that is selected for an RCT may not reflect the patient presentation what is coming to our practice. Okay, case reports also give like practice-based evidence. Okay, that means whatever I have seen the patient, I am just establishing the evidence that I have treated such a patient and I found these findings. Okay, so case reports are very valuable for practice-based evidence. Of course, when I was telling you about cross-sectional studies, there are different types of studies like Delphi study. That Delphi panel and then consensus development also contributes to practice-based evidence. Okay, so make sure that you upgrade your skills, get the knowledge, proper training on what are all the different studies which we can do. Get your research question matching that it should be for diagnosis, and then you perform the research according to the reporting guidelines. And make sure also there are something called as clinical prediction rules. Okay, in that prediction rules for diagnosis is also there. For example, cervical radiculopathy has a clinical prediction rule. Rotation, contralateral restricted, positive upper limb aerodynamic test, Sperling's test positive, okay, in compression. So all this combination of 4 to 5 findings, where 4 findings are there, you can confidently tell that it is cervical radiculopathy. Okay, published none other by our colleague, best friend, Professor Joshua Cleland. Okay, so remember that there are people who are working on these all aspects, even the validity, the sensitivity, specificity of special tests. There's a separate textbook on evidence-based orthopedic physical therapy diagnosis. Okay, so it's a very, very useful text. It tells about palpation, it tells about movement testing, range of motion assessment, muscle strength assessment, everything, reliability, validity, every region. Okay, so it's a great commendable work by the author to compile a huge number of publications and summarize and present it as evidence. Okay, so in importance to therapeutic studies, we are going to see further later. Okay, we are going to see only today, that is the diagnostic studies. So make sure that when you do validity, there are different types of validity. Okay, for the diagnostic accuracy. Okay, for that actually the measurement is measuring what is supposed to measure. So you have to compare with another tool which is already established, which is actually called as the gold standard tool. So your tool is the test tool. Okay, if I am doing an SLR, for example, straight leg raise in a patient with an intervertebral disc prolapse, I want to see that whether SLR can detect abnormalities of a disc injury or a sciatic nerve injury. Okay, then I should compare it with the gold standard tool of, if it is MRI, minor interruption due to the internet connectivity. So this is the part number 4 of the webinar number 11, Diagnostic Studies in Evidence-Based Practice. So SLR versus MRI, for example. So SLR detects that the positive is a symptom distribution. Okay, and then you do the MRI for confirming the disc bulge. MRI is very important only for the extrusion and sequestration. There was a previous webinar done on evaluation of low back pain and also discogenic low back pain. You can refer upon those free webinars for further information, details, type of disc bulge and why. So what you have here is an SLR. You have got it, it is positive. The patient is telling pain, shooting pain. Okay, an MRI which is telling the disc bulge or posterolateral with sciatic nerve, the S1 radiculopathy, the nerve root compression, either from L4-5 or L5-S1 intervertebral disc posterolateral. So can you say that the SLR is accurate to detect? We don't have to do MRI for the future for the subjects. Most important is sensitivity and specificity. Okay, The SLR will detect, okay. If it is negative means there is no disorder, you can tell, okay. If SLR is negative, you can confidently tell there is no S1 radiculopathy, sciatica, okay. So that's why ruling out it is present. So it is sensitive, snout, okay. So a sensitivity of the SLR is good because it is negative means you can rule out that there is no radiculopathy of the S1 output. What comes to specificity then? SLR is not specific, okay, it's only sensitive, but crossed SLR is there. You lift the normal leg, well leg raise test. When you are lifting the normal leg, shooting pain is coming here in the affected side. Patient has reported in the symptom that is reproduced in this affected side, symptomatic side, when you lift the normal side, okay. That is crossed SLR positive. Crossed SLR is supposed to be more what is called as ruling in the specificity, okay. If a patient has a positive crossed SLR, confidently you can tell he has a posteromedial disc herniation which is leading to S1 radiculopathy on the symptomatic side. So that's the story of this, sensitivity specificity. It's very, very important to know this in clinical practice. Many of us do the SLR, we may not do the crossed SLR. Many of us get one of the thing positive, another thing not positive. We don't know what to interpret, how to diagnose. Okay? It's because we don't go after the literature for sensitivity and specificity for any of our examination procedures. Okay? Even history taking, for example, would also be studied for reliability and validity. So you cannot leave anything out of scientific testing. Okay? And gold standard on what basis it is decided? Okay, it's because it was earlier being used, so it's gold standard. Okay. Otherwise, there is no. If you are devising you are finding out a new device for range of motion, you might use a goniometer as gold standard. Okay. But it may not be scientifically acceptable all around the globe. You might use an electrogoniometer, then everyone will agree. Or you use the isokinetic device to measure the range of motion, that also world will agree. There are special devices which you can measure the range of motion like inclinometer, that is also agreed. So there are some things which are even motion tracking system. Okay, so you keep some opaque markers on the joints and then movements are done. All the pictures are overlapped in software and then you see the degree. Okay, that's done in biomechanical analysis and movement analysis in sports. Okay. So that is also another globally accepted method, so you can use it as a gold standard. So everything you need to have what is called as a gold standard, then only you can measure for the criteria tool or the test tool. In JMMT there was a research published for the joint mobilization gold standard. Okay, so always everything it comes under the picture, and it is important to consider when you are actually performing the diagnostic studies what type of things you are doing, for what purpose you are doing. Questionnaire development is a more technical work. Okay, lot of computer work is needed. English language, team, everything is important. And that questionnaire should be studied again for pilot. You have to distribute it to the experts, get their validation, what is called as content validity. Okay, and then after that you go for this criterion related validity, which is comparing with the gold standard. Another questionnaire you might compare. Okay. Sometimes you might even compare the English version with the Hindi version. Both of them, what score they are bringing out on a subject, who understands both Hindi and English. Okay, you might administer both the versions and see for the validity of the Hindi version. So remember that multiple procedures are there. Okay, and do that and contribute to the creation of further evidence. We need more diagnostic evidence. That's why I have kept the diagnostic evidence as first. And tomorrow we are going to see a particularly unique type of studies, that is the next webinar, that is qualitative research. Qualitative research is to do with the feelings, the perceptions, attitudes, behaviors, psychosocial factors. So on that, exploring that aspects, okay, experiences. The fourth type of evidence, that is qualitative research. First one is diagnostic, therapeutic, prognostic, then qualitative, the experiences. So that we are going to see in the next webinar. So diagnostic research in evidence-based practice, the session is open for questions. Participants who are able to see me live here because of the internet connectivity, if they are having a good internet, definitely can post here in the comments so that I will try to address them directly and live. Participants who are not able to see me live because of their busy schedule or because of the internet being very stingy, not working, then watch this video later. When you watch it, please put your query and send me the screenshot. Okay, so either I will answer you in WhatsApp itself or I will answer on the Instagram here. Okay, so here we are ready to close the session for the webinar number 11, Diagnostic Studies, and I really thank all of you for your patience to keep connected with me.